What is rehabilitation and how does it work?
Thank you for inviting me. This talk is going to be partly philosophical, partly practical. The clever bit of the talk is to try and not overlap too much with my colleagues in therapy and whatever, who will be doing a lot of the practical stuff. But I thought one of the questions I get asked is, what rehabilitation would my client need and what should we be recommending? And I think one of the problems is people don't get a really good handle on what we mean by rehabilitation, and sometimes rehabilitation goes on for a very long time, particularly when you've got a young person who's injured in childhood. And also, one of the things that I see often when I do revisits is people have had quite a lot of rehabilitation, but there isn't a really very clear goal, a clear outcome, a clear understanding of what the rehabilitation processes are. People often become very focused on some of the physical issues, such as physiotherapists, because it's very tangible. And yet, you know, is what you're commissioning value for money, and is it hitting the mark, is really what I hope to address in this talk. So what is rehabilitation? Well, first of all, it's a process of active change, and a lot of it is around developing knowledge and skills needed for optimum physical, psychological and social functioning. So it's an educational process, and I don't think a lot of people generally understand that at the outset. They think, well, I'll see a physiotherapist and she'll do something to me and I'll meet her for an hour a week and I'll be fixed and my life will go back to normal. And actually, one of the things that I was having a conversation with Sarah about earlier is that what we need to do is put in place something that's going to be a lifestyle change. It's going to be a 24-hour change, and the therapy is going to be adopted fairly early into lifestyle changes. You can also have a service definition, which is all means to minimise the impact of disabling conditions to assist disabled people to achieve desired level of autonomy and participation. And that's a really critical point, because it may be that somebody has life-changing disabilities and will remain disabled, but you can put in place equipment, systems, advice, care, etc. that's going to not necessarily alleviate their disability in itself, but improve their levels of participation, to involve them in social roles and to make their quality of life better. And when I talk about quality of life, I want you to hold on to the idea that autonomy is absolutely critical. Even if you are Stephen Hawking and very incapacitated, you can still be autonomous, and sometimes that's actually what we're trying to aim for when we're talking about rehabilitation. And I say it's active participation, and you may say, well, what about all my clients who are in minimally conscious state and persistent disorders of consciousness? And I would say it is still about optimising that person's quality of life, but in a way that looks to their social participation, not just and their communication and their expression of themselves as a personality, rather than simply to physically improve them. And also, what is a goal? I mean, we beat ourselves up about this as a profession all the time, because we say, oh, goals, let's have some goals. Let's tell the patient what their goals are. Oh, my goal is to become my hip to be stable. I've never really worried about my hip being stable, and I don't suppose patients think that either. The trouble is with goals, if you're not careful, it becomes fantasy football. What's your goal? Oh, well, I'm going to walk again, doctor. Well, obviously. But actually, the skill of goal setting, I think, is the skill of rehabilitation. And I think it goes across everybody who is participating, from lawyers through to every clinician that's involved. Can we set a goal? So it's a future state, what you might be desired or effective. It's a generic term, so you can have a short-term goal, a medium-term goal, a long-term goal. You might have a long-term aspiration, but that aspiration will need to be broken down into other goals. What you might have to do is have a discussion with your client about what are their values, what's important to them, and therefore how can we set goals that are going to be appropriate to their values, even if they can't do the actual actions that they want to. Goal setting, I think, is really important. It's about agreement, and it's not about fantasies insofar as if the defendant's experts are going to look at what we're recommending and they're looking at what's being funded, they want to see what the actual outputs are going to be. This is quite an interesting factor because this is the BSRM standards for rehabilitation services, but I think this could be applied to rehabilitation in any setting. It's got to be a 24-hour process. Seeing a physio once a week, but your family doing everything for you the rest of the time, isn't actually going to cut it. Looking at postural management, looking at behavioural management, how you put in place behavioural goals, it's got to be 24 hours. It's really important that there is interdisciplinary planning. And that can be quite difficult because patients can have a multiplicity of goals set by different therapists, some of which perhaps may be in contradiction to each other. So again, you're commissioning a team that's going to be interdisciplinary, and things are going to be carried out by different people. It's not going to be, this is your physio homework, this is your OT homework. The family needs to have information and they need to be participative. And one of the biggest concerns I will get if I go and assess a patient at home and I say, what's the name of your physiotherapist? I don't know. You know, how does that work? You know, or have you seen an occupational therapist? You know, we need to make sure that claimants are seeing the value because it's got to be participative. And ideally, it should be active and agreed. And this is difficult because patients are on a journey and there's a lot of adjustment there. And I think you're probably saying to me, well, welcome to my world as a case manager, how I engage my clients in having realistic and meaningful goals. So, I'm assuming this is going. Oh, can you? So, I mean, there are a lot of services involved and there are a lot of specialised services. This is just an overview of the sort of NHS services that are involved. And people will have involvement with all these services. I'll draw your attention really to the Neurorehabilitation Level 1 and 2A inpatient. This is specialist inpatient rehabilitation. This is what happens on the journey after people have been through A&E intensive care, and ideally these are funded, they're funded through NHS England. They have a particular set of standards. My 2 units are commissioned as level 2, 2B, but we send in audit data, national audit data, as to our outcomes. And actually it's been very valuable because I think knowing what rehab units do and what standards they set, I think is really important. And there are standards for things like staffing. But also what we're short on is community rehabilitation and vocational rehabilitation in the NHS. And I would encourage you to consider all of these three on the right, really, how we provide long-term support, how we provide community rehabilitation and vocational, and how we prescribe end-of-life care. And these are all probably areas where the sort of claims that you're working on are going to make value added. Right, I don't know why this is just briefly, busy slide, but just to say that when they've number crunched the national audit data, they basically find that it saves money. There's strong evidence that rehabilitation is effective. There's strong evidence that intensity of rehabilitation is effective. There is strong evidence that it saves money. And basically, if you can get somebody from 2-to-1 care to 1-to-1 care, you basically pay for a period of inpatient care within 14 months. So, you know, highly specialised inpatient rehabilitation units will save the taxpayer money in the long term. And the next one. Community rehabilitation, there's strong evidence base that it does work, and definitely we need to be prioritising it. Unfortunately, even the best NHS services probably only provide 6 to 12 months of outpatient organised rehabilitation. So there's some really, really good stuff, but unfortunately, things like vocational rehabilitation is extremely patchy. And therefore, those are the sort of areas in which you want to be picking up, is people who are perhaps into their second and third year of recovery, who still have ongoing rehabilitation needs and goals. So hopefully, community rehab gets people launched at home, it reduces equipment needs, it reduces care needs, but we need to go on one more step, which is looking at vocation and the areas that improve later. And so if I just get you to press the button twice, because these slide on for a reason, and one more. So when we talk about the International Classification of Function, this is one of our favourite slides at the University of Leeds, because one of the things we don't always think about when we think about people who are disabled is we don't think about the bigger picture. Basically, somebody can have an impairment of their body and structure and function. They may have, for example, an amputation or a brain injury, and that just describes the impairment. However, what they are capable of doing with the right environmental factors, and the right personal factors, having enough money, will be considerably different to another person who may have a comparable level of impairment. So impairment is not deterministic of how somebody either completes their activities of daily living or necessarily participates in the wider society. So activity limitation are your different activities and skills. OTs will tell you lots about this. And participation is really where it's at, which is whether you can fulfill your social roles. So if you are a disabled person, you can fulfill your social roles. You can vote, you can be a parent, you can be a spouse, you can direct your own care, you can go where you want to on holiday. These are all participation level goals. And you know, we may not be able to alleviate the disability, but we can certainly think about how we can adjust those other factors to take into account. So when we're thinking about rehabilitation, I invite you to think holistically about the ICF model. So next one, please. It's worked this time. Rehabilitation interventions are by nature, they are complex. That's why it's quite hard to study them. You know, you will notice that people talk about the black box of stroke units. You know, we know stroke units work, but it's taken years to determine what those aspects are. It's quite difficult to define what is the intervention. We know it's a bit like psychotherapy. You know, how does psychotherapy work? Well, or how do different ones work? Well, we don't really know. We just know that there's a relationship between the therapists and the client that has a desirable outcome. And rehabilitation is actually quite similar in that way. But what we do know is there is always an element of learning to rehabilitation. It's about the client learning. It's about the client taking on. It's not about the client making their muscles stronger. Yes, they are doing it. But effective rehabilitation is about a learning process. Going on to the next one. The other thing is interventions are based in systems, they're based in lifestyles, they're based in life. You can't just do it. It goes back to this 24-hour important way of looking at things. Interventions are prone to modification as they're implemented, and they need to be personalised. And that's really the skill of the therapist. That's the skill of you therapists in the room, that you are implementing a personalised intervention based on scientific hypothesis and making principles. So that's really what you're looking at. They're open systems that change through learning as stakeholders. So you may set out to deliver rehabilitation in a particular way, but you are constantly updating it in the light of the 24-hour environment. So on to the next one. So you can intervene at a number of levels, really, and this is a conceptual diagram, really. So you might be looking at restorative skill acquisition, so you might be looking at improving somebody's physical function. And there's all sorts of things that you might be considering as additional factors. So supported treadmill training, exoskeleton, whatever, robotic systems in order volumes of practice, virtual reality. My colleagues at Hull are doing loads of work on looking at virtual reality in terms of rehabilitation, both in safety, in balance, in mobility, wearable devices, drugs, some stuff on things like TMS, not something that I don't think has got a strong evidence base at present. But the idea is that you might develop skills, but with additional devices that might assist. Measurement, you might look at how you might look at people's movement, their analysis. You might use gait analysis, you might use video, you might look at ways of measuring what the effect you've had in order to tailor your intervention. And then you might have actually compensatory strategies, but again, the sort of rehab technologies where people are working on those, things like orthotics, seating, assistive technology, communication aids, they're all, if you like, compensatory, but there is a overlap between compensatory and skill acquisition. And so you can think about interventions in quite a complicated way in terms of the overlap between your three functions of rehabilitation. So on the next one. And these are just some illustrations of really where sort of research is going in terms of looking at the sort of interventions that rehabilitation could be looking at in the future in terms of interventions, because actually whether we can do robotic training to increase ability and increase volume of practice, and a lot of these interventions are trying to look at ways in which you can use additional volumes of practice to be able to do things, simulations if you will, to try and increase ability. And the next. And again, things like interactive care, interfaces, lots of stuff in prosthetics. I mean, paradoxically, one of the biggest investors in rehabilitation research is the American military, because people do all these things like eye gaze for dropping bombs, and then they can use it for eye gaze. You know, when they talk about friendly fire, it's when somebody blinks in the wrong place. Some of the work's on exoskeletons and on orthotics are actually around people being able to work on shipyards, you know, with heavy equipment, you know, and it's quite interesting. So, you know, there are enthusiasts who are working in areas of rehabilitation to try and push the boundaries of how we can deliver more. So the next sort of three series of slides are just really the sorts of patients that we perhaps will be involved with. And this is just an example. This is very typical of a sort of patient that has been on a level 2A rehabilitation unit. It's a young man who's had a bad TBI, diffuse axonal injury, subdural, he's had a surgery, he's in a rehab unit, he's got a dense left hemiparesis, he's got sensory issues, but he's also got frontal lobe behavioural issues. And this is somebody who's going to probably take 2 to 3 years of quite intensive rehabilitation before you're going to see really where you're at with him. He's, I mean, without any spoilers, he's somebody who got into walking. He was able to walk, albeit with limited indoor walking with some supervision, but it was his cognitive problems that probably were the most significant in terms of determining his care needs in the longer term. But if I just go on to the next slide, so What do we do as medics? Well, first of all, we look at neurological examination and optimization. So what we want to do is we want to actually say, so what exactly is wrong with the patient in a fairly holistic way, and how much can we intervene? Can we treat somebody's bladder? Can we treat their bowels? Can we treat their swallowing? Can we have a look at their pain management, their spasticity management, etc.? Those optimize things. We might even look at, further investigations or further concerns. If somebody has got comorbidities, how are we going to treat those? So we're going to look at those in a way. We're going to look at things like epilepsy. Are they on the right anticonvulsants? Maybe they do better on a mood stabilizing anticonvulsants rather than on Keppra, which may be irritating their some of their behavioural difficulties. Actually, medical optimisation, and in a good medical report, you will get us to comment on really the sort of medical interventions. It may be that recommendation will be neuropsychology, neuropsychiatry, and we would generally be recommending MDT involvement and co-working, because this is complicated, and if individual therapists are going to throw different interventions at this situation, I think it needs to be holistic. And interestingly, in this particular case, the situation was very crystallised because the care package became critical because his mother actually had to have some breast cancer treatment, and therefore it was suddenly everything became very critical, that the care team had to be consistent. They had to deliver the behavioural and the physical interventions. The case manager really had to step up in actually saying, this is what we need to do to achieve and to manage this. And actually the complexity of managing this with all the other family dynamics going on is really very important. Looking at the next one. So, just so you know, this is just one illustration of one thing. This is a gent, obviously, who's got a dense left hemi. He's got significant spasticity both in his arm and his leg. What we're trying to do with his arm is he's got a paretic arm, so he has very limited usage, but he obviously has a very strong associated reaction, and he's at risk of developing contractures in his fingers and wrists. In terms of his leg, he's got a very stiff calf, but hopefully he's somebody who was actually a client for botulinum toxin, really, in order to manage some of those focal tonal issues. But again, when we're thinking about spasticity, we're thinking about pain and positioning, orthotics and maintenance. We're thinking about triggering factors for his spasticity, and we're talking about avoidance of long-term changes with regards to, for example, shortening of his Achilles tendon. So this is an example of another typical case, and this is somebody who's had a high-speed RTA, who's in a persistent disorder of consciousness, essentially. And so this is a different sort of rehab case, but this is somebody who's had long ITU, prolonged coma, post-traumatic amnesia, profound physical problems. So we're doing a lot of work to try and optimize physical condition, alleviation of pain, spasticity, regular positioning, looking at the sort of reflexes that they're having. And with somebody like him, we are trying to optimize his posture and his communication. And we're using a number of tools and modalities. So, you've probably, again, just want to pick out one small aspect of this intervention, is you've probably heard about SMART testing, sensory modality and rehabilitation technique, which is a particular technique, but looking at systematic ways of assessing people's cognition is absolutely critical in this stage. It's very tempting in this case to talk to families and they say, oh yes, he understands absolutely everything. And often families project a great deal onto people in this position, and some of it's wishful thinking and some of it can be quite difficult. And I'm doing quite a difficult case at the moment where the patient's partner is, very pushy, and she's very she's very loving and very caring and very pushy, but her understanding of his level of understanding isn't borne out by the medical evidence. And I slightly feel that she's very persuasive towards some of the legal team who are involved with her, and it's quite difficult to hold your ground as an expert and say, look, you know, this is what's being shown. So just to illustrate that the SMART is basically, as you say, sensory modality and rehabilitation training, and it's a bit like doing a Glasgow coma scale, but across a different number of modalities. And basically, the levels go from minimal to maximal. So, you know, top level, you know, will be 7, and then, you know, 5 is very much somebody who's consistent, wakeful and aroused. And you can, and basically between those areas there are systematic ways of determining what is somebody's best score and what is somebody's typical score. You will also come across a measure called the Wessex Head Injury Matrix, which is a bit more practical for day-to-day usage and is helpful for you to get an understanding. And again, it will tell you what is somebody's best score and best ever score and what is their highest consistent score. And one of the things about these scales is that they are hierarchical. So if somebody's only capable of doing this far up the ladder, the chances of them blinking 3 times for yes and twice for no aren't actually that great because we have a hierarchical recovery. So again, this is a sort of patient you might send to a rehab medic for an opinion on, but you know, thinking about how you're going to assess cognition is absolutely critical before you're deciding on all the expensive assistive technology, etc., that you will be recommended, I guess. Moving on to the next one. And this is the third group, big group of people who you're going to send to me. And this is my lovely local second chance group. And you'll probably recognise some of the people in the group. If you move on. So, I mean, what I call the walking wounded, well, everybody calls the walking wounded. Sounds a bit Miranda, that, doesn't it? What I call. Actually, these are people who've made a really good physical recovery but have got significant ongoing executive dysfunction related to frontal lobe injury, and they can have executive behavioural issues, impulsivity, and they have difficulties with behaviour, emotional regulation, and they need a lot of support. And interestingly enough, because they can present so well, they're going to run into quite a lot of difficulties. If they have very poor insight and quite a reasonable level of preserved cognition but very poor executive function, they're extremely difficult to look after because their actual understanding of their need for support is relatively limited. And so, oops, let's go. So going back, I mean, so they need a lot of education, support, assessment, monitoring, understanding. A good neuropsychologist will work with the client around not just testing them, but understanding where their strengths and weaknesses are and trying to get that level of understanding. Sometimes I think that the situation can be quite difficult because if the family are also in denial about it, it's very difficult to judge somebody's insight when their parents are actually saying, well, you know, we're doing this case, but, you know, they're going to be fine afterwards. They're going to go to work. He just needs to pull his socks up. I mean, who'd have a pound for every time a client, you know, the parents say that? You know, he just needs to pull his socks up. And it's that fundamental understanding. Assessing people in function, you know, actually somebody can do quite good on a pencil and paper test, but what are they like out in the community? This is where you're garnering evidence around witness statements and things to actually show how people actually behave in real life situation. The family need to support and monitor the behaviour throughout the 24 hours. And one of the difficulties with managing behaviours is actually to get that, to go back to the original thing about 24-hour rehabilitation. It's even more critical in things like neurocognitive rehabilitation as well as physical rehabilitation. There are a group of people who, a proportion of them will need vocational support. There's a group of people who actually do reasonably well and actually can get back into some sort of supported employment situation. And actually a lot of people don't, because of a number of configurations of factors. So we've got to be a little bit sure about the ethics in terms of you as lawyers, because you might be a bit of a risk-averse lawyer who says, well, you know, he's probably not employable, you know, and then the client reads that as, oh, I better not go back to work because, you know, I'll lose more money, and then it all gets a bit mad. Whereas actually a really good vocational rehab with really good data, and somebody's done their best and got back to work in a sheltered setting, do you know what? That's pretty good, and that's pretty sound evidence in my view. Moving on to the next one. So this is actually a slide about memory, and this is just to say that memory is a massive, massive thing with brain injury, and how we access things like working memory is absolutely critical. And this is just an illustration of how many bits of the brain actually contribute to somebody's memory when you actually think about it. I mean, everybody talks about the hippocampus being very specific, and you've all seen people with hypoxic brain injury who have very, very impaired short-term memory, quite a pure deficit in short-term memory in some cases. But actually, this is just an illustration of the complexity, so it's not at all surprising that people have problems with their memory. And the fact that we need intact frontal lobes and an intact executive system to access things like attention, memory, language, and therefore it is important to understand the complexity. Just looking at the next one. And what is executive functioning? Well, I mean, again, this is another slide that just looks at the complexity of what we mean by executive functioning that we're trying to rehab people from. You know, they're people with conceptual ability. Can somebody really understand the situation? Do they have mental flexibility? We've all met people with black and white thinking related to their brain injury. Some people were fairly black and white before their brain injuries, and it doesn't improve the situation. People who have problems with inhibitory control, you know, they're great, except that, you know, they want to go out for a drink and then they lose all inhibition and they need two-to-one care to take them out. People with problem solving and strategy formulation, planning, self-monitoring, initiation. So paradoxically, you can have somebody who's impulsive but lacks initiation. And that can be quite a complex situation. It can be quite confusing. And, you know, Andrew's talked about people being videoed. So it's amazing how many people get videoed and they're, you know, they're walking around aimlessly or what have you. And actually, you know, they illustrate all of these things on the video. The defendants just think, well, you know, they're walking around shopping, and they're not. They're walking around aimlessly. Sequencing of behaviour, people understanding how to do things in sequence, people weighing up decisions, people making time judgments, people being able to do things in a timely fashion, people being able to organise themselves. And these can be relatively subtle. You can have somebody with a relatively good level of recovery, but you can't quite get them back to their original workplace because of these subtle high-level problems. Personality, well, I don't need to speaking to the choir in this room, but you know, people who have altered personality or more intensive versions of themselves beforehand after brain injury. And Sarah's point about divorce and family breakdown is absolutely critical. And social behaviour, theory of mind. Can you work out what the other person's trying to get at? Is really, really important and really difficult in people with brain injury. And the next one. What they call divergent thinking defects. People who can't do two things at once. People who can't multitask. Spontaneous behaviour, strategy formation, planning. Poor abstract thinking. People who can't think ahead. You know, all very disabling and yet relatively subtle. So next one. And interpersonal behaviours. So people might be disinhibited and inappropriate, altered behaviours. People who end up in the criminal justice system because of impulsive behaviours. People who are just really flat and quite expressionless. And people who just, you know, they're not quite the same again. I mean, for completeness, people who've had a brain injury are at increased risk of having other psychiatric illness. So you increase your risk of developing other psychiatric illnesses, and we need to take that into consideration. And then finally, you know, these are people injured in childhood. And so if we go on to the next slide, people who have really good recoveries in childhood, but they've set up latency so that they can't always, they don't always develop at the same rate. They get up to the sort of adolescent executive function development period, and they become more impaired as they go into teenage. So somebody appears absolutely great, they go back to their infant school. Typically the sort of 7-8-year-old gets run over because they're not safe crossing the road or what have you, and then they start falling behind at 12, and by the time they're in their mid-teens they're having quite significant difficulties. By people who don't launch into young adult functioning, biological, psychological and social. So children with physical impairments who don't get the experience of taking on social roles, interacting with others without the support of parents. So delayed in maturity in young people with, for example, cerebral palsy. People who need to be assessed from an adult neuropsychological point of view, because people can be far behind their peers in childhood, but by the time they reach adulthood, they're considerably further behind. People who need to formally learn adult independent living skills, they don't pick them up automatically. People who need to adjust to adult roles. Experiencing discrimination. I mean, one of the biggest things I think is young people with cerebral palsy whose parents perhaps offer them a lot of rehabilitation, a lot of interventions, a lot of physiotherapy, etc. Say, well, you can do anything you want to when you grow up. And they get to 18, 20, 25, and they're clearly a long way behind their siblings. And there's significant ongoing adjustment issues. A lot of parents who say, well, they're going to live with us forever. You know, the typical parent of an 18 to 20-year-old will believe that they'll live there forever. By the time they're 30, it's actually a really different story. And so how we support people in this position is important. And helping people to self-manage, helping people to both accept their disability and to make the right choices around managing their disability. And this is true with kids with diabetes, asthma, transplants, heart conditions. People with disabilities from childhood need to have that support and those skills. So when you're thinking about somebody injured in childhood, these are all considerations I'd encourage you to think about. And this is just an illustration of the myelination of the brain. You've probably seen lots of diagrams like this, and the take-home message is that there is a rapid development of the grey matter followed by a period of pruning and myelination. And people have done sequential neuropsych studies of people injured in different parts of their teenage, and different patterns of behaviour tend to accrue depending on what part of this critical stage that you've been injured. And so people who are injured in early childhood can present very much like cerebral palsy cases. People injured in junior school are different to people injured in adolescence, and those in late adolescence can still have significant problems. On the next one. And I've mentioned all this really, that we need to have age-appropriate assessment tools because people can fall behind if they're injured in childhood. And the next one. So rehabilitation is goal-based. It's important that you have appropriate early rehab. You need long-term intervention. You need intensive input early on, and you need to collect evidence about effectiveness. people can benefit from technology, particularly this interaction with technology and therapies, but technology isn't a thing in itself. It's only as good as the clinical prescription. Failure to provide early therapy actually can lead to important losses. But we need to be thinking about realistic expectations and think about latency in childhood. So on the next one, so I'll do conclusion and then there's a few extra slides. So we've got to basically say, you know, we've got to think about what's biologically possible. One of my jobs as a consultant in rehabilitation medicine is to prognosticate. That's one of the things you're paying me to do, is to say, what's the nature of this person's disability? And what do they need, you know, what is their potential with good rehab? Contrary to popular belief, physiotherapists do not walk in and go, oh, I'll give somebody some physiotherapy and see what happens. And yet you'd be amazed what the popular conception is well, you can't tell, doctor, you can't tell how, you know, we could surprise, you know, we've got to keep our hope. And actually what you're paying us to do is to make a clinically reasoned prognostication about good rehab. We have to understand how the mechanisms to make rehabilitation tailored and effective, and we need a strong understanding of the International Classification of Functioning, the impairment activity participation model, because you as lawyers are going to put in the resources to intervene on those modifiable levels. You're going to be able to put in place resources that are going to modify the impact of the disability. And there are lots of available new technologies that people are working on at the moment. But I would encourage you to think that the purpose of these technologies are to provide independence and autonomy, but they're also only as good as the therapy support. So kit in itself is not a thing. So just a few final sort of little slides. So just to carry. So this is somebody I know. This is a gentleman who had a brain hemorrhage at 18 in 1958, before they'd invented scans. Burst aneurysm. He was in intensive care for 13 days and had 3 brain operations for it. He was left with a right hemiplegia, no full use of the upper limb, but with quite significant foot drop and significant aphasia. Went through rehabilitation back in the day when people did, with a lot of physiotherapy, OT, speech therapy, although I gather the occupational therapy was largely around making cheese straws. And regained a lot of speech, reasonably fluent, well, fluent speech, very fluent writing, but with an ongoing verbal dyspraxia to a degree. Never quite as articulate again, but got back to university within 2 years, got back and did a degree in history within 2 years, but was left with the long-term effects of hemiparesis, but had a really quite significant limp. So if you go to the next one, so went to the Brook Hospital, read politics and modern history at Manchester, and then was employed for over 30 years as a specialist careers officer, subspecialising in people with disabilities, so doing a lot of vocational rehab and working really with getting people into work. And just back in the day when it wasn't about checklists, when actually taking people along to employers and selling people on schemes to do sheltered employment. And the next one, so basically got involved in the careers service, worked closely, was very grateful to his neurosurgeon, who both enabled him to get a driving license in 1970 when they changed the rules on epilepsy, and enabled him to get into the local authority superannuation scheme so he could get to work back in the day before they invented disability rights, and just followed him up for a long time. And basically on retirement, did a whole shed load of voluntary work with a lot of different people, with employment, Disabled Graduate Information Service, chairman of Employment Education Committee at Radar, involved in a new link company, a vocational rehab company, worked in the City Council in equality and diversity, and was an active member of NOT's Coalition of Disabled People. And what were the things that made the impact? What were the big money things? Well, number one, the neurosurgeon making sure that he got to work and was supported. Driving. This is a picture of what his first car was like, because that's the only thing he was allowed to drive. And then over the years, a lot of maintenance. Certainly orthopedic surgery to fix up things like clawed limbs and things like that. Orthotics from his 50s, because his foot drop became more problematic, less stable, more falls. Got one of the early FESs and thought the world of it, thought that was very good. And good support in terms of rehabilitation after periods of hospitalisation for injuries and illnesses. And then basically at the age of 57, good support from Occy Health to be able to retire early because of issues with headaches, fatigue and physical stability. And moving on. And this is the last 10 years of his life. These were the people who kept him going. This is Natasha, who some people in the room know, and this is basically a physio and gym practice where there is a physio practice in the front of the building and there's a gym in the back of the practice with a lot of peer support. And this enables people to go in and exercise and stay on your feet a bit longer. And basically, this was a person who who got back to work, got back to life, got married, had 2 kids, got back to family life. And if you show you the last slide, this is him, and this is his daughter. There you go.